when we have to carefully assess, using the full range of therapeutic options, which treatments to use, whether IL-17, IL-23 or JAK inhibitors at the beginning of residency, it's always important to thoroughly, diligently and meticulously review the treatments we prescribe, and thoroughly. And be able to choose the best option for our patient, because ultimately we need to aim for more personalized medicine. Let's see if we can identify some key points to help us choose these treatments. Alright, so let's start with the IL-17 inhibitors. In this family we have secukinumab, ixekizumab and bimekizumab. Preferred indications in general? Well, they work very well for predominantly axial involvement, with very high effectiveness shown in studies. Additionally, for patients with severe peripheral arthritis, especially when there is active inflammation in multiple joints and they also have contraindications to other drugs. And a very good response has also been observed in extensive moderate to severe psoriasis, even outperforming anti-TNF treatments. There are also indications for severe enthesitis and dactylitis, and it's truly indicated across all domains of the disease. But it's important to keep in mind as contraindications as such. Contraindications for choosing these drugs include patients with recurrent fungal infections, candidiasis, where there's no effective way to treat the candidiasis, and it just keeps, well, in that situation it wouldn't be a good option. It's true that even if candidiasis does appear in a patient using this treatment, if you treat it, sometimes it can be resolved and that's it. But well, if these are already recurrent cases, it wouldn't be ideal to pursue that route. And in general, it's important to know, and this is crucial to keep in mind, that it is not recommended for patients with inflammatory bowel disease because of the role that IL-17 is known to play in the function of our gastrointestinal barrier. It can worsen this disease. As for IL-23 inhibitors, we have Gucel and risankizumab. As preferred indications, just like in the previous case, in cases of extensive or moderate to severe psoriasis, it is an option even above anti-TNF, especially when there is predominant peripheral involvement. It is a drug that can work very well, but it's important to keep in mind that in terms of axial involvement, if our patient has both peripheral and axial involvement, or if the involvement is predominantly axial, we should not focus on this pathway because studies have not shown robust effects. Regarding comorbidities such as inflammatory bowel disease, in this situation, unlike with IL-17, here they do play a role. Risankizumab is in fact approved for ulcerative colitis and Crohn's disease, and Gucel is still in phase 2 studies both for ulcerative colitis and Crohn's disease. In addition, these are drugs with very convenient dosing schedules. Gucel is administered every 2 months and risankizumab every 3 months. As for relative contraindications, it's important to remember that in patients with predominantly axial involvement, it wouldn't be a good idea. Also, in patients where we need a rapid response, they're very slow, but we do have drugs that act faster, like IL-17s or the JAK inhibitors. When we go on to review treatments with inhibitors such as tofacitinib and upadacitinib, the generally preferred indications based on patient profile would be a patient with combined axial and peripheral involvement who is generally refractory, intolerant or unresponsive to other biological treatments, and also with involvement in domains such as enthesitis and dactylitis. And keep in mind that in inflammatory bowel disease, these drugs also have their indications. UPA is approved for both ulcerative colitis and Crohn's disease, while TOFA is currently approved for ulcerative colitis. Additionally, one of the major advantages of these medications is that they are administered orally, which is beneficial for more apprehensive patients, as it eliminates the need for self-injecting medications, going to the day hospital, and receiving the treatment there. As for precautions or contraindications, it's important to note that there is an increased risk with a recommendation regarding the potential to trigger shingles, herpes zoster. In fact, it is advisable to vaccinate patients who are going to start this treatment and to exercise caution, especially with older patients, particularly those who have had shingles, who have a higher cardiovascular or thrombotic risk or an increased risk of malignancy. This summary table can help in a detailed and comprehensive manner to emphasize those pathways, those domains of the disease in various aspects. where treatments are most appropriate. As we emphasized regarding skin involvement, the IL-17 and IL-23 pathways have shown superior efficacy, and it's important to remember that IL-23 is not a good option for axial involvement. To a greater or lesser extent, effects have been demonstrated across the other domains as well. And to summarize the profile of the patient, we would treat with IL-17, IL-23 or JAK inhibitors. IL-17 is suitable for psoriatic arthritis with severe skin involvement, high musculoskeletal burden, and even axial involvement. We do not recommend it if the patient has Crohn's disease or ulcerative colitis. And in addition, for patients who need a rapid response, it is a very good option. IL-23 is suitable for patients who, like the previous case, have predominantly cutaneous psoriasis as well as active psoriatic arthritis, severe but without significant axial involvement. They are safe in inflammatory bowel disease. It is true that Gusel, as I mentioned, is indeed still in the second phase, and risankizumab, which is approved for both inflammatory bowel disease conditions. That dosing convenience for patients who may have difficulty adhering to treatment, well, IL-23s also play a role here. And JAK inhibitors, well, in general, we would say they are for patients without cardiovascular risk factors who have been refractory to several lines of treatment with severe polyarticular disease and also inflammatory bowel disease, as in the case of UPA, which is approved for both indications, and TOFA, which is only approved for ulcerative colitis. A treatment that provides a rapid response is also oral and offers that added convenience.